And it's part of the standards that there's some mention. It's not only standards how to collect the data, but how to really make them comparable across time.
Across time. So shall we go back to what Jason alluded to previously, going to the lowest denominator, steps, the simplest metric, the easiest to measure, perhaps. Because if we keep switching algorithms over time on about intensities and all sorts of other aspects of physical activity, that could be hugely problematic. Before Andreas, I would like to ask Stephanie, always having health surveillance in mind, what can we learn? What could global surveillance learn from Canada? Because you've been doing it for a few years now. It's over a decade, if I remember well?
Yes, it is. So the CHMS is in 2007, they started using the ActiCal accelerometer. Yeah. And so it's been a long time. And so we're actually doing some work again, looking at trends using different metrics right now, but it has certainly given a glimpse into trends in Canada and looking at physical activity levels and also other metrics such as sedentary behavior. So I've done a lot of work on sedentary behavior surveillance. And interestingly enough, like when we look at the accelerometry data, it looks fairly stable across population groups. The things with the accelerometer data, though, in the Canadian Health Measures Survey, it's a nationally representative survey, but it is much smaller than the sister survey, the Canadian Community Health Survey, which is more questionnaire based. So the CHMS is, because it collects all these physical measures, it is a smaller sample size, and we can't use it to look at subpopulations, so provincial and territorial estimates. We have to use the CCHS for that. And so that's the thing with surveillance and monitors, is that they are really time and cost intensive. And so while, they do augment or provide additional information that we don't get from the questionnaires, they are usually on a smaller sample that could potentially bring its biases with it. But they are also really intensive to analyze and to get that data. And so I don't think that, we need to remember that when setting up these like international surveillance systems, just the scope of the infrastructure that's required to set them up, to establish how we're going to analyze these data, because the data files themselves are massive as well. And so to be able to look at, a per minute amount of data on thousands and thousands of individuals requires huge infrastructure in terms of storage of the data as well.
But the advantage, if you collect raw signal, is that you can always go back to historical data and reprocess them with a new algorithm. So that perhaps overcomes the problem of algorithms and standards improving over time. Thank you, Stephanie. Very useful lessons from Canada. Andreas, and then Aidan.
Yeah, I think you were present yesterday about the presentation from Christina in using the Motus, the Sense system, where we have an infrastructure now, which means it's very efficient, feasible to do this type of data collection. And I think it will just be more and more of those type of infrastructure with fully automated analysis, you get the information, feedback straight on, right? But I think it also, what Christina showed yesterday was the big issue is about how to reach low socioeconomic groups. So we don't already measure on the rich and the higher socioeconomic groups, but how to reach those in the lower socioeconomic groups. And I think there also, I think the wearables, the commercial wearables might help us, because they are really good, right? With respect to making it should be attractive, it should be valuable, it should be promoting them to have it. And I don't know if you get funding, so those not having that much of an income, that they actually might get the sensor or the wearable, or how to be able to reach those groups. I think that's the main issues we are having with respect to how to analyze it and infrastructure. I think we can handle that quite in a quite long way.
Thank you, Andreas.
So I've probably got more of a question than a comment then. So it's probably a question to either Tessa or Stephanie then. So I can see, we definitely want to have a nice representative sampling in various countries. Very soon, I would maybe argue as soon as possible, we should be incorporating device-based measurements in lots of countries. I was quite struck by Tim's presentation beforehand. I think that 90% of the population plus have got a smartphone. And obviously Manus has talked about STEP. might there be opportunities to piggyback on top of smartphone measurements? And of course, it's a noisy, messy measurement, but at a large scale and maybe looking at trends over time, could it perhaps be useful for surveillance? I'm wondering aloud.
Tessa, that's for you.
Thank you. I'll go to Aidan's question first and then maybe see if I remember what I was going to say otherwise. But I think it's really interesting you said that, Aidan, because I had exactly the same thoughts back at that presentation. I think from my perspective, but I'm happy to be corrected, I think we need to remember that when we talk about consumer wearables and the similarities between activity trackers that we wear on the wrists and how similar they are to the research grade devices and how there are some the limitations and the differences have been pointed out to us. But I think we need to make sure that we don't carry all those advantages over to smartphones because they're not always there. People wear their smartphones in very different ways. It's not a 24-hour measure and people wear them in different positions a lot of the time. And so whilst I think there is a huge opportunity with them, I think we need to be aware that there may be further barriers to using smartphones, particularly when representativeness is not just who's collecting the data. We may overcome that with smartphones, but we may not pick up their most represented parts of the day. It may be that we're only picking up the active part if people want to measure their steps or this kind of thing. So I think we do need to be aware of those limitations, but it's not to say it can't happen, but I don't think it's a straight transfer across. And I think the other thing I was going to say relative to the point Andreas made about using consumer wearables and surveillance, I think one of the, and the sort of attractiveness to low and maybe less affluent groups or just harder to reach group, I think we need to remember that with surveillance, we really don't want to affect people's activity levels. And these devices are behavior change devices and that they're providing feedback to change behavior. And that really is a problem for surveillance. So is it the behavior change features that are making it attractive? In which case, is that a problem for surveillance use? And do we kind of need to cover that up? I don't know. But I think that's just one of the issues around consumer wearables. It's not insurmountable, but just something we do need to consider.
Thank you. Stephanie, and then we'll be wrapping up the surveillance issue and we'll be moving on to primary care, wearables in primary care in healthcare systems. Stephanie.
I was just going to, also echo what Tessa just said at the end there with the idea of reactivity to the monitors and the idea of the research grade accelerometers, the actigraphs, the acticals, they can't get any information from those devices while they're wearing them. And oftentimes we even do, like in clinical research, when I was working as a postdoc, we often did the chop off the first and last day, because when we actually look at the data, usually they are higher than the in-between days. And it often is because people are, conscious that they started wearing it and then conscious that they have to return it. And so just to keep that in mind with surveillance, these wearables, I think there is an element of reactivity, and there's also more of an element of wear time. So when people are wearing them, how long do the battery last? How long do the battery last? I know when we were working in cardiovascular research, that was a huge challenge because patients, to add something else on top of their daily lives where they're, stressed, to add that they also have to charge their device every day or every, couple of days, depending on when we want them to wear it, was an added stress. And so that certainly is a challenge also with using the wearable devices from a surveillance perspective. That standardized wear time is really important for surveillance.
Excellent. So lots of challenges with whether we go down research grade trackers or the consumer trackers. Sounds like there's no perfect solution. Even smartphones seem to have some advantages in terms of representativeness, but there's no solution that stands out for global surveillance. I would like to now, so we discussed, we said before that the ultimate goal, why we're doing all sorts of research, from surveillance to cohort research to interventions, is to find ways to help the population be more physically active, with a view to ideally preventing disease through better sleep, through better physical activity, improved physical activity, and less sedentary behavior. Now, primary care. All of us operate in countries with universal healthcare systems. Am I right? Yes. Canada, Denmark, UK, Australia. Tim Chico drew a very grim picture of NHS and the future of integration of wearables in cardiology care in the first instance, but I believe that Tim's perspective was applicable to the whole NHS. Now, here in Australia, for example, it's slightly different. It's not that wearables are everywhere in primary care, but you see a few practices, they have the independence and the autonomy. And a few practices, for example, have adopted Fitbit's Connect ecosystem, which allows them to monitor physical activity via centrally via GP practice of patients who own such devices, or in some cases, fewer cases, patients are given devices. Mark, I would like to ask you the grim picture that NHS seems to present at this point in time. What do you think would be the practical steps towards start integrating wearables in primary care with a view to preventing, to improving behaviors to prevent chronic disease, non communicable disease?
Yeah, and those practical barriers shouldn't be minimized in that way. But that's the case for a lot of medical devices in healthcare. There's quite a number of hurdles, and most of which take so long to come over that to overcome that it's not worth implementing the device in the end because the devices have changed considerably. So that's a particular burden. In my introduction, I should have also, I was remiss in noting that I was invited partly because I'm a member of the Cancer Research UK People and Populations panel. And so one of the things that we're particularly struck by, whilst just activity is a priority for prevention and particular populations, is the low quality evidence we have around linking physical activity to the wide range of cancers. There's pretty good evidence on a limited range of cancers, and it's a bit kind of moderate level evidence and not overwhelming associations in certain cancers. That's probably because of the nature of the instruments we've used to measure. So it's a sort of a noise in, noise out type phenomenon. And so I think the first thing we have to do is to, get a bit more clever in our epidemiology around a broader range of diseases and a bit more stronger level evidence for the risk factors. And then from that, determine what the minimally clinically important difference is in terms of activity change using wearables of whatever kind we want to use, because that provides an intermediate target for either disease prevention or disease treatment. We would do that as par for the course in all of our kind of medical type interventions, where activity is the outcome. I think the other thing is we need to make a much stronger case around the health economics of investing in prevention. We know in the UK that preventive services get a really small portion of the overall healthcare budget. And there's a lot of political lobbying to be done, and we do around further investment in that. And part of that's around health economics. And I think if I'm, speaking in broad terms, the information we can get from wearables will give us much more refined understanding of the associations and the potential cost savings of intervention. The third point I'll make then, and I'll finish with this one, is around our education of our clinical colleagues. So I'm a non-clinician sort of behavioral or physical activity scientist working in a clinical medical school teaching, in the medical pathway. And I noticed this on funding panels. I noticed it in undergrad students. I noticed it in clinical colleagues that they have a fairly crude understanding of what physical activity is and what physical activity change involves, largely around moderate or high intensity exercise. So kind of limited view as to what the potential behaviors we're trying to change are. And so I think there's a lot of education to be done around not just the benefits, like everybody knows physical activity is good, what kind of activity and for whom. In my own area of older adults, where we see clinicians prescribing or certainly encouraging, recommending older adults take part in, unnecessarily vigorous activity when they're previously inactive. Now, I'm not saying we don't work up towards that, but I think it's been able to train and teach our clinical colleagues as to how to both counsel individuals around physical activity change and behavior change in general. And that takes a lot of time, both in training. So most medical courses have hours, not days, devoted to behavior change. I taught, the course I taught, we literally got 3-hour session across a 5-year course to teach behavior change, not just physical activity, but the psychology of behavior change. And really that's almost redundant.
It sounds like a systemic issue here. It's a systemic issue around physical activity and lifestyle in general, as opposed to whether we use wearables or not in primary care.
Yeah, I think that's the start point. Is that system problem, and that starts with us about giving better quality evidence to prove that it's a good, a stable biomarker for disease prediction or prevention.
Thank you, Mark. Is the reality in Nordic countries different in Finland or Denmark, Andreas and Sari? Is there any more integration of wearable devices or smartphone-based interventions, technology-based interventions for physical activity in primary care?
Yeah, well, I mean, I can start and Andreas then comments on how it is in Denmark. It is not incorporated in a wide range, but I'm thinking like in rehabilitation, it is people are using it very widely. And I'm thinking regarding Mark's comment that in the hospitals and the primary care, we have the specialists for physical activity, the physiotherapists. So I think they could be used more here to help the physicians also to in recommending and giving guidance to physical activity. So that is something that we need the collaboration between the different professionals. And I think in the rehabilitation we see that it's actually these wearables are really great tools, and there you really engage the patients to their own treatment, so they feel that they are doing something about it and they can measure it. So in a case where you have a certain condition that you really have motivation to improve, so then these kind of devices where you can get feedback and you get the measurements and how you make progress, I think they are really valuable.
Thank you. Andreas, in Denmark, are things different? Or Norway, because you are representing two countries, essentially?
Yeah, I'm not sure. I don't think it's very much different. I've been involved in some projects with respect to implementing mobile phone instruments with respect to low back pain in general practice. And that's shown really positive. But I think in the end, we need to have more studies showing the cost benefit of using these type of devices in general practice. So I think that's what we need more of to document and give evidence about that it's actually improving behaviors. Changing behaviors.
Thank you. Aidan.
It was just, I guess, to reiterate support then for what Tim said earlier. I think we need high quality randomized controlled trials of devices, and primary care, I think, is quite a good area to look at that. I often think it's quite interesting then, for example, the Q-risk score for cardiovascular disease, or even the score in European context. To my knowledge, there's been no randomized control trials actually showing the use of those scores actually does help improve outcomes. Perhaps there's an opportunity for us in the physical activity or device community then to really lead the way across biomedicine and to really embrace conducting some good high quality RCTs in this space, and ideally looking at some hard clinical endpoints as well.
Thank you, Aidan. And Jason?
So thank you. It's been a fascinating discussion. To me, there's maybe 3 different reasons why someone might use a device in primary care. So one is to get data for epidemiology. So your new risk prediction model might be able to incorporate physical activity. You need to collect it in routine to do that. So that's one reason. Another reason is the reason that Tim talked about, to try and help the clinician diagnose whether a patient is sick or likely to get sick. And then the third reason is you might help change their behavior to make them do something or benefit their health. So I think we can make a case for the first 2 quite easily. I think for the third one, I think we need better evidence that giving someone a device will change their behavior long term. And I don't think we have that. We get this reactivity initially, that everyone will increase their activity for weeks to months. We see that with almost anything. But I think we've got pretty much zero data to say giving someone a device means they'll be more active 2 years down the line. And I think we need to do trials on that. And I think it's naive to think just giving someone a device will do that. I think we need to work out how to have the device within a behavior change package that supports people to become more active, if that's our goal. There's good reason to do it just for the epidemiology and risk prediction and all that. But if we want to do behavior change, just giving people a device, I don't think will do it on its own.
A support system ideally involving humans, not only AI.
Well, we can do trials. We can randomize people to device plus an AI-based support system, device plus a human-based support system, look at the effectiveness and the cost effectiveness, because it might be the AI system is half as good, but it costs a tenth as much. So you're better off doing that. So I think we need to do trials. I think we just don't know at the moment.
I think you made an amazing, incredible point, Jason, which is that the device itself is not necessarily an intervention. It's a component of an intervention. It's a component of behavior change.